So it's a pleasure and a privilege to welcome you to this very special grand round, one that allows us to remember a very special young man every year alongside his remarkable family. Gregory Mark Taubin was the son of Joel and Sonia Taubin, who are here with us today, and the brother of Gary Taubin, who's also here, and Stacy Taubin. While a fifth grader at Potomac Elementary, he was a class president, an honor student, and an excellent athlete. At the age of 11, Gregory succumbed to Reye's syndrome in the Pediatric Intensive Care Unit of Children's National, despite the application of every form of neurointensive care and therapy available at the time. Gregory's parents will tell you that they remember every minute of the time they spent at Children's. And through their remembrance, the Taubin family has touched the hospital in so many meaningful ways that you will see their names here at Children's almost everywhere you look. In the neurocritical care portion of our pediatric ICU, the media room, the kosher kitchen, and even those wonderful amenity bags for families who arrive when a sudden illness does not allow them to prepare. And among their many gifts to us is sponsoring the annual Gregory Mark Taubin Memorial Lecture. So I'm proud to introduce Dr. Jim Marcin as this year's honoree for the Taubin Lecture. Jim is born and raised in California. He went to college and medical school at the University of California, San Diego. He did his residency at UCSF. His pediatric critical care fellowship, however, he left California. When he tells the story, he says he left California because he wanted the very best training possible. So he chose to come here to Children's National to obtain that training. He also obtained an MPH at George Washington University. After fellowship, Jim joined the faculty of the University of California, Davis, and was promoted to professor in 2009 and appointed as division head of critical care medicine in 2013. Now, Jim's CV strongly reflects his Children's National roots. His first 10 papers, many co-authored with Murray Pollack, focused on quality issues in the pediatric ICU. At UC Davis, his research interests evolved over the next several years to extend his passion for healthcare quality into and out of the PICU through the use of telemedicine. Jim is a born innovator, and he has combined that with almost limitless enthusiasm and energy for testing his ideas in rural Northern California, one of the largest and most underserved rural areas of our country. He's received incredible amounts of funding from the NIH, from the ARC, from HRSA, and multiple foundations, and he's the author of nearly 100 manuscripts. So with no further ado, we'll have Jim come and talk to us about telehealth and the PICU virtually there.
Thank you so much, Robin, for that very kind introduction. All that, my wife still wants me to do the dishes. But I want to thank everybody and say welcome to those that are coming in by video, particularly for this talk regarding telehealth. And in particular, thank the Taubin family. Again, as a fellow here, I have vivid memories of the Taubin lectureships and the visiting professors, and it's had a profound impact on my training. Specifically, I remember it was way back from 1995 to 1998 is when I was here, but specifically the thrust of the education under the Taubin series was communicating bad news to families, and that was very early and innovative for its time in the late 90s. I don't know, probably one of the first centers to focus on communicating families and doing it effectively and doing it in a humanistic manner. So it's a big, big honor for me to be here, and thank you very much for this honor. I have no financial relationships or conflicts of interest to disclose. So I'm going to kind of go very quickly through telehealth, and I'll start. And I know that there's lots of programs here at Children's National, and you do a lot of telehealth work, international, local, things like that. But I'll start off with a few basic slides, and the first is the definition. And there's different definitions for telemedicine. Telehealth Institute of Medicine has one. CMS has one. Telemedicine Association has one. But basically, it's just the delivery of healthcare over a distance using telehealth technologies. And there's typically 3 different categories that it's broken down into. One is live, interactive, or synchronous telemedicine, and that's just the basic Skype. And the classic example of that is outpatient telemedicine, where a patient can go to their local primary care provider and see a specialist over a far distance using video conferencing technologies. The second kind of bin is something called store and forward or asynchronous telemedicine, and that's teleradiology is a classic example of that, where they can send an image over a distance and the radiologist, not necessarily immediately, but can review those images that way. It's done for ophthalmology, dermatology is common. And increasingly, it's being used in other applications, for example, in mental health, where structured interviews can be then recorded over patients, and the healthcare specialist can review those recordings and recommend diagnosis and therapy in an asynchronous manner. And then there's a third category that people use, which is called remote patient monitoring, and that involves a lot of different technologies, both live and store and forward technologies, where you can monitor patients at home, in another ICU, collecting data with their glucometers, blood pressure cuffs, things like that, to be able to monitor patients at home that way. The whole premise upon which telemedicine is based, and it's not necessarily a new concept, right on your right there's a front cover of a radio news magazine in I don't have my glasses, 24, there where they talked about using telemedicine way back then. But it's based upon the premise of balancing 2 different facts. And one is that regionalization of healthcare, we know, improves efficiency and improves quality. And that's why there's prestigious hospitals like Children's National, where you're able to have all of the expertise located in one center, and you're able to maintain volume and proficiency of a lot of otherwise rare diseases. And it would really dilute that quality if we were to try and do this in every single hospital that way. But that model of care creates disparities in access, right? So if you live in rural areas, you're not going to be able to get that same access as those that live in the urban and suburban areas. But with telemedicine, we're able to deliver that access to where the patients need it. And more so that's being done in rural areas, but it's also being done at home. And so we can maintain the regionalization and the efficiency of care this way, but at the same time deliver it directly to the patient where they need it. Overall, the use of telehealth is on the rise. Last year, it was calculated in 2014 that there were 20 million telehealth encounters in the United States, and that's expected to go to 150 million by the year 2020, which isn't, even though it sounds like Jetsonian, it's not so far away. So that's increasing, and the applications are increasing. And again, it's typically outpatient, but more and more people are using it for more innovative ways. There's also, on the financial side, been exponential investment in this, and this is from a global financial forecasting firm that caters to Wall Street here. They expect a lot of money and a lot of patients to be using this more and more over time. So there's been, again, a lot of investment in this. The 3 major telehealth providers that are doing direct-to-consumer care, for example, have raised more than $250 million in the past 2 years to get telemedicine startups this way. One quick bragging point, I come from a children's hospital that I guess can fit in this children's hospital's back pocket. It's a children's hospital within a hospital, and it's, again, very humbling to be here. But one of the things that we have focused on a lot is telehealth. We've connected up to more than 140 different locations throughout California. This is for adult and pediatric here, but routinely connect between 80 and 100 sites, independent sites, to deliver care throughout the course of the year. And as you can see, there's some places down in Southern California where we deliver care too, but I assure you that there are physicians and group practices and specialists in Southern California that are delivering care to patients even north of us this way. So this technology is really allowing patients and providers to connect over regions that they hadn't done previously. I'm going to go quickly through all of the different applications, but this is going to be a summary list, of course. Again, I mentioned the first application is for outpatient subspecialty consultations. That's 80% of what we do in pediatrics and adults at UC Davis, and probably across the most the other telehealth or telemedicine centers across the country. The bread and butter is the outpatient telemedicine, but more and more it's being used for inpatient telemedicine and ICU consultations. It's being used in emergency departments for trauma and critical care consultations. The last HIMSS survey had 50% of their hospitals reported using telemedicine in one way or another, and in the emergency departments, it's 15%. Majority of that is for telestroke on the adult side. It's also being used, as you do a lot here, Dr. Craig Sable is an international leader in what he does with the pediatric telecardiology, transmission of echoes, EEGs, other studies so that specialists can read those. There's increasing utilization of it for home monitoring, for chronic disease management, in particular diabetes, asthma, congestive heart failure on the adult side. International telemedicine, again, Children's National is the leader in that. It's also being used in schools and daycare centers. There's a handful of centers across the United States. I have a couple of slides on this where they're delivering care to children in their setting, which is at school or in the daycare center. Using chronic care facilities and more with palliative care and hospice care, again, with the patients with special health care needs. And again, you guys have a national leader here with Dr. David Steinhorn in that. So I'm going to focus a lot about what we've been doing, or my expertise, which is the inpatient and the ER telemedicine, but kind of briefly touch on a little of the other things. The idea, if you haven't been sold on the use of telemedicine, you can say, well, why doesn't the patient just drive to us? And clearly this mode of technology is patient-centered. And there's enormous amounts of data to show that families and patients prefer not having to travel great distances to go to a busy exam room with other sick patients when they can go to their local healthcare provider and see their specialist that way. So it certainly is patient-centered. There's a lot of data also to suggest that it increases overall quality of care. And typically this results from improved communication between the primary care provider and the specialist. Rather than the patient coming to the specialist, he or her giving all of the recommendations, the letter may or may not get to the primary care provider. There's not really good communication between the primary care provider and the specialist. And this mode of technology, again, using telemedicine, has been shown to increase the identification of the patient with the primary care provider as their primary go-to person, which is, more consistent with the medical home. There's also data to show that it's increased capacity in care. There's something called Project Echo that started out at the University of New Mexico, where when you're doing a consultation like this and you involve other providers, primary care providers, their education and ability to take care of these more complex patients that they're referring to you as a specialist becomes greater. And so over time, they become more and more comfortable and more of an expert like you. Project Echo is the extreme of that, where the physicians, the specialists don't even spend time necessarily with patient encounters, but they're reaching out to primary care providers on the management of complex medical conditions so that they themselves can do that. And under this model of care, you're able to take care of more patients, all at a higher level of quality of care. There's also increased efficiency of care. A lot of times our subspecialists, the kind of bread and butter, and I give the example for pediatric gastroenterology, for chronic constipation and things like that, they a lot of times prefer to do that over telemedicine. They send out their evidence-based guidelines, and then the patients that they kind of have come to them in the clinic in person are the ones that they really need to lay their hands on, or perhaps are lined up for procedures that way. And then there's also data that it can reduce costs. Of course, there's a cost of technology involved here, but as it goes down and the ease of its use is increased, there's data to show that it reduces overall healthcare costs. And that can be because, one, it can help hopefully keep patients out of the emergency department, and perhaps if you see them at home out of the clinic, but it's also been shown to reduce the number of testing that's done. So when a patient's seen by their primary care provider, they do a bunch of laboratory tests, things like that. They come to the specialist. What do? We repeat all of those tests. That's less likely to be done when you're implementing the telemedicine. Again, so I'm going to go through, talk about its use in the emergency department, inpatient wards. We at UC Davis have been using it for, 15 years to communicate and help care for some children that are hospitalized in adult intensive care units. But before you shoot me, I'll explain a little bit about that further. And our newer application, and others are doing this as well, in newborn nurseries and remote NICUs to be able to provide subspecialty care there. We have a program called PNET, and this is Dr. Robin Steinhorn, who gave the introduction, was very involved with this and involved with one of the grants that we received called Pediatric Emergency Assistance to Newborns using telemedicine, and I'll talk a little bit about that model of care as well. So first of all, for its use in the emergency department, I'm pediatric critical care. Lots of sick kids come to other hospitals that aren't a children's hospital. And it's 600 miles if you go north of Sacramento to the next pediatric ICU, which is in Portland, Oregon, and there's a lot of kids that live between there. So what we've done is we've set up video conferencing or telemedicine units in a lot of the emergency departments, and again, we've been doing this since 2000. We have 28 sites. I have to admit, for different reasons, either physician turnover or different referral patterns, 24 of these are active. You put it there, it doesn't always work that way. But we've worked very hard to have the use of video conferencing integrated into existing process flows so that it's very easy for the providers, the doctors and nurses in the room, emergency departments, and easy for our doctors as well. We've done more than 450 consultations to date. You can say, well, that's a relatively low number, but our primary focus has been in critical access hospitals, where they only see a handful of sick children per year. But when they get a sick child, they really, really want to have our help. This is a video here. It's made by the local television station, so it's kind of geared toward that audience here, but kind of demonstrates how it worked for this family here.
Avery was 1 week old and dying in the emergency room at Sonora Regional Medical Center.
She got really sick really fast.
A transport team was on the way to rush her to UC Davis Children's Hospital, but they wouldn't arrive for 2 more hours.
Her breathing was really labored, and she was cold to touch.
In the Sonora emergency room, Dr. Donald Dudley needed a pediatric specialist now, so he switched on the telemedicine cart.
This was actually the first time I didn't happen to use it.
Dr. Francis Poulain, a pediatric neonatologist at UC Davis Children's Hospital, appeared in the emergency room in Sonora in just minutes. Not in person, but through telemedicine.
So I could ask him, what do you hear? What do you feel when you examine the patient? And he was giving all that information.
Dr. Poulain could do almost everything except touch the patient, but he didn't need to do that to diagnose the problem.
So the hunch that I had that this might be a heart disease, which is very peculiar to that age group, was confirmed very quickly.
To have a set of eyes that knew what they were looking at just from so far away made us feel in such a very scary moment a little bit more comfortable.
Dr. Poulain in Sacramento and doctors in Sonora, connected by telemedicine, worked together for more than 2 hours to save Avery.
So I could see that the therapy that we had initiated was starting to take effect. So it was very gratifying.
But there's no question that it made a dramatic difference in our ability to, in a real-time fashion, manage the patient.
Many doctors are skeptical about the benefits of telemedicine, but there is no doubt in the minds of these doctors, telemedicine saved the life of this baby girl.
Avery would not be around. She would have died that day.
I was extremely thankful that we had it.
But any hospital that doesn't have it or they're on the fence deciding whether to get it or not, it's definitely a great investment. I always say if it saves one life, it's worth it. So
it saved our daughter's life, absolutely.
And surely it will help to save many more.
So that's a baby that presented to an emergency department in the Sierra Nevadas 2.5 hours away. The only way to get there was by car during the weather, and presented with a closing coarctation. So it had a pH of 6.8, a base deficit of -33, and of course Dr. Poulain, who's a neonatologist, connected up and said, we need to start prostaglandin, and as you can imagine, the ER doc there wasn't so familiar with that medication, but, you know, with the video conferencing, we were able to get the pharmacist to come down to the local pediatrician came in and did all of this work in time while their transport team was able to get out there. And I think, you know, this is a good example, and I would have to say that each one of my 9 partners has participated in, you know, we do a lot of these consultations, and every once in a while you're like, doggone it, without telemedicine, I think that there might have been you know, trying to do this over the phone wouldn't have been the same as using over telemedicine. So a lot of my career and what Dr. Steinhorn had mentioned about getting grants has been trying to evaluate the impact of this on quality of care. And I have to say it's not been easy, because when you do this and you say, yeah, I was able to see the patient and things like that, demonstrating that with an objective outcome hasn't been the easiest thing. A lot of times in telemedicine, people use satisfaction surveys, and so we certainly did this. We handed out satisfaction surveys to similarly critically ill children of kids that came in and got a video conferencing telemedicine consultation versus the standard telephone consultation. And this is just 3 of 7 different measures that we looked at on a Likert scale. And overall statistically significant higher on the yellow bars were telemedicine. The parents thought that the doctors and nurses were more courteous. They thought they were smarter. Their overall impression of the quality of care that they received in the emergency department was higher with telemedicine. Again, don't know if that's they're wowed with the technology or they appreciate consultation, but that was something good. We also give providers to the referring ER docs and says, you know, hey, how helpful was our consultation over the phone versus telemedicine? And not only were they more satisfied, they thought we were smarter when we were doing something over telemedicine. Maybe we're less rude to them than we might be on the telephone or something. But they also felt that our consultation had a greater degree of impact on the change in diagnosis, their thought process of what was going on, the addition or change in medications that we suggested administration, and in the change in disposition. So a lot of times they'll call and sometimes we say, hey, well, that kid doesn't necessarily, we'll take the child, but he's not so sick, or we don't need to send a helicopter for this child, we can just go by ground and things like that. So there's a frequent change in disposition this way. The other thing we try to do is really try and evaluate quality of care, but there's not a lot of explicit measures that are out there where we can do this, you know, standardized measures to measure quality of care. So I spent a lot of time developing what's called an implicit review instrument with our quality experts at UC Davis to be able to apply to this. And what we did was a retrospective chart review on the sickest kids with similar diagnoses across the board. We reviewed 320 charts from 5 emergency departments using this process of structured implicit review, which looked at 4 domains of care. It's kind of it's a subjective scale on a Likert scale of 1 to 7, but where the experts look at the medical record and judge the quality of care that's been provided. Again, on the initial presentation, their initial treatment, their diagnostic plan, their therapeutic interventions, and their discharge plan on the patients. And we found, after risk adjusting, this was not a randomized trial, we found this is standardized for odds ratios here. When it became unblinded, we were very happy and relieved to see, or I guess kind of what we expected, that telemedicine was, those charts were rated as having the highest overall quality of care that way. I had the honor and pleasure in having my former mentor write the editorial on this article here that was published in Critical Care Medicine. This is like my big work after coming out of fellowship. And that was the title, Pediatric Emergency Department Telemedicine's No Answers and More Questions. But Dr. Pollack told me that was a typo in the editorial office. What he meant to write was more answers and no questions on the editorial. It was a rave review, and I appreciate my mentor doing that. I've been waiting 2 years to say that. The other thing that we did on another cohort of patients is we had 2 pediatric pharmacists review these records, identify, and this was, again, hopefully a well thought out process. So, you know, what is a medication, you know, just boluses and things like that, and what constitutes medication errors. Again, we looked at the sickest kids, looked at 187 charts, 4 emergency departments, again, multivariable analysis, and again, after unblinding, we found that standardized to no consultation, which is in the blue, there were fewer medication errors when there was a telephone consultation, and when video conferencing was used, there was about 1/3 of the likelihood of having a medication error, physician-related medication error in that emergency department counter there that way. Another thing that we've looked at, you know, I've been doing my best to try and really evaluate the impact of this model of care in a lot of different aspects here, but we were looking at the appropriateness of transfer. We used Dr. Chamberlain's model here called PRISA, Pediatric Risk of Admission here, that was developed at Children's National Medical Center, also with Dr. Pollack. And we looked at the discharge ratios of patients, whether or not they're transported inappropriately. As you can imagine, the folks in the rural emergency departments say, get this kid out of here, and you would like for them to err on the side of safety, right? But at the same time, you don't want to have them fly in a helicopter for a kid that doesn't even need to be in a hospital and displace the family and things like that. So with those patients, if we can help keep them in a local community, we do that. And we found a 10 to 20% fewer transports using telemedicine, using both the PRISA score and the repeat score. And we also enrolled the help of health economists to look at this. And we tried to look at it very, very detailed, looking at the cost of telemedicine, the cost of the equipment. We pay to have 24/7 tech support. All of these costs were included in the cost of providing telemedicine this way, and in the savings that resulted in that. And again, that's from a reduced number of transports, reduced helicopter transports, and because our hospital is more expensive than the community hospital, the cost of hospitalization, we found about $4,600 cost saving per child per ED using this model of care. So doggone good stuff. And then the other thing that we're looking at now, this is unpublished data I'm looking at with a graduate student, and our hypothesis here is that these emergency departments that we've been working with a relationship with telemedicine over time, that they're providing better quality of care overall than the emergency departments that haven't adopted telemedicine or that we're not working on with this way. So what we did was we compared patients that have these telemedicine in their emergency department versus non-telemedicine emergency departments. What we looked at was we looked at a similar severity, similar diagnostic category patients and looked on arrival, are they more or less sick when they arrive? On the far left, we found that their average PRISM-3 score, again, that's developed by Dr. Pollack here, a risk of mortality, it's lower when they use telemedicine in the yellow. They have shorter length of stays, and they're less likely to die in the hospital if they're coming from these emergency departments that are utilizing telemedicine. And again, we have them matched at the beginning so that there's similar severity of illness on presentation to the emergency department. So we think that we're having an impact on the care of these children from the get-go and really changing the culture of care. This is also being used, I mentioned, on wards. We do it at 2 hospitals at UC Davis where there's community hospitals where they have pediatricians but no subspecialists, and we're providing our subspecialty consultations to them at the bedside as if they would receive that in our own hospital, right? We want to be able to provide that same level of care at these community hospitals. And this is another study that was done out of Portland, OHSU, by Dr. LaBerba there, and she looked at 153 charts. And this is, again, it's not a randomized controlled trial, but she looked at the pre-hospitalist and pre-telemedicine cohort, then they got a hospitalist, and then they implemented telemedicine that way. And they found a reduction in the number of kids that needed to be transported from this community hospital, both from the emergency department and their ward. And she also looked at something called downgrades, which is, hey, this kid needs to come to your ICU. And when they send out the transport team, they can say, hey, well, maybe this kid can go to the ward. They don't need to be transported to the ICU. So the frequency of these changes in disposition also dropped among this cohort of patients. So in a lot of ways it can help. This is this is probably about 8 or 10 years old of a consultation we did in an adult ICU. And again, our model of care here is to not have sick kids in a non-pediatric ICU, that's for sure. The idea is that for marginally sick kids, a kid that might need continuous albuterol for a couple of hours or something like that, rather than flying them down 150 miles from this adult ICU up in Northern California, we might be able to manage them there. They're a level 2 trauma unit, so they have adolescent and 12, 13-year-old trauma patients that might need observation in the ICU and things like that. And we kind of help them manage these patients this way. And this is a patient that came up from the emergency department that an adult critical care physician admitted, but was not in-house, right? Like a majority of the adult ICUs here in the country, not manned or personed 24/7. So this.
And I would dial the pressure control.
The audio isn't so loud here, but the nurse at the bedside there call for pediatrics to be able to get help about the patient until the doctor came in from home.
6 to 8 cc's per kilo.
And I'm not sure if they can turn up the audio, but our doctors is able to move the camera around, look at the ventilator.
How often are you guys cycling the blood pressures?
Are not high-tech way of looking at vital signs.
Every 5 minutes, or even every 3 minutes.
Streamed, but this is a low-budget way. You can see the patient's hypotensive here, 93 over 33. You'd be able to assess the chest rise on this file.
You know what? You can probably come down a little bit because you're giving her a much bigger chest rise.
Do you want to try to see her foot here?
Yeah.
Able to evaluate capillary refill.
Okay, go ahead.
And that's not good for the non-clinicians in there.
Yeah.
I mean, you can see he's got his arm up. He's a little bit frustrated that the doctor isn't there yet. I'll just jump ahead right now. The doc did come in. The patient got transported to our ICU after a lot of volume resuscitation, epinephrine, walked out of the hospital, did well. But this was a child, again, without video conferencing. They would have been still trying to get in touch with their doctor by telephone, or maybe our doctor by telephone. But our doctor was really able to bridge that time period for that other physician to come in there. Again, it's not the ideal model of care. This is data, gosh, it's back 11 years now that we looked at this, the data from taking care of patients in this adult ICU, and we looked at 107 different patients and found that when we compared it to, they would admit between 100, and here they had 230, so this is over a 2-year period, admit between about, 80 to 100 pediatric patients to their adult ICU. They tended to consult us on younger patients. You can see here by the mean age, higher severity of patients, and their efficiency. And again, this is a definition developed by Dr. Pollack here. About half of them were on the ventilator or had vasoactive infusions. And not that this is the appropriate use of PRISM 3 here, but we're not trying to keep patients that are near death there in their adult ICU at all. The one patient that did die, that was a pediatric patient, was a near drowning patient that wasn't expected to live. And we thought we really did the right thing for the family to keep them there in their local community as opposed to transporting them to our ICU 2 hours away and having the patient expire that way or pass away that way. So we were able to help get the patient on the brain death protocol up in their hospital that way. So again, the idea is not to keep the sickest patients there, but the intermediately sick patients there. This is one of the findings that I like to show off from the study when we were giving surveys to the bedside nurses, therapists, the parents, and then the referring ICU doctors there. We asked them a question, how important is it that we keep this child here in the local community, this pediatric patient? And on the left, this is, I dichotomized our Likert scale. This is extremely important. You can see the RN and RTs, you know, 60, more than half of them say it's very important that they be able to stay in their own community. That's where their support structure is, that's where their house is, all of that stuff. And you can see what the doctors thought about that, right? And you can imagine that, say, hey, I get the kid out of here, things like that. And so, again, I think it's, you know, our fault for not recognizing the imposition that we impose upon patients and their family when we have to transport them long distances. When it's necessary, of course, that's what we do. But if we can use video conferencing to help keep them in the local community, I think we're doing the right thing. Something quickly on our nursery telemedicine. Again, this is the pediatric emergency assistance to newborns using telemedicine. That took me a while to come up with that PNAT acronym. But we have a number of nurseries around here. This is Sacramento here, a number of newborn nurseries primarily, just regular deliveries. And some of these hospitals are doing 200 deliveries a year, very, very low volume. But the idea is to help out if there may or may not be a pediatrician in a local community, family practitioners, if there's an unexpectedly premature delivery or a patient comes out depressed, if there's problems during delivery, if they need to be cooled, all of these things. And then there's also a cohort of patients that we've been using it for, like if a baby comes out a little bit tachypnic, a little bit hypoglycemic, or the mom might have had a fever and stuff like that. Is this a patient that I need to give antibiotics or send to you, or can we watch him here and things like that? So we've been doing this nursery telemedicine here too. And see, I have so many doggone videos. I'm not sure which one. Oh, this is a baby that was born at Enloe Medical Center in Chico. And again, our transport team was launched right when the baby came out.
Do you think you can get a UV feed quickly and easily? That's what I would go with right now.
The baby, and our neonatologist and cardiologist in the upper right was able to
for the vein, if it's not going easily, I would put some downward traction
blood test
on
and
the umbilical stump towards the
by the
baby's
time
toes.
the transport team was able to get out there. Again, I'm going to skip forward on this. You'll see she's
and then insert the catheter almost at a 45-degree angle.
You can also see this is not the best sterile technique. Again,
so,
the old film.
the other way, down towards the baby.
At one point, his finger actually touches the glove.
So once you're in about 5 centimeters, you should be able to draw.
Yeah, and then at the end of it, he's like, well, it made me really nervous that you're looking over my shoulder. And she goes, well, I can hang up. And they're like, no. The whole room is like, the nurses were like, no. This is another example. Again, and this is where we have telemedicine and a complete neonatal ICU. It's a community ICU, so like a level 2 in California. A baby was born with SVT. Neonatologist up there called, we're going to intubate this baby, transport down to SVT, and our neonatologist/cardiologist says, well, hey, let me take a look at this baby.
Okay, I'm not going to be able to see her off clear.
And again, she's driving this part here.
Let's
and she's going to put the pads on the baby, and so the baby's going to get shocked with 2 joules.
Whenever you're ready.
You'll see the baby. Boink. But I shock my kids at home with a lot more when they miss me hit. So that's SVT, normal sinus rhythm. Again, a pediatric cardiologist.
Okay, we need a rhythm strip of that.
In her office. I'm sorry to say this, Robin, but the neonatologist never took his hands out of his pocket. Good thing, right there when it stressed him out there. And that baby was able to stay there. Oh gosh, I'm going to get in trouble, you know. But that baby was able to stay there. You can see the baby's a little bit tachypnic there. That got a lot better. The heart rate came down.
Yes, it's sort of anticlimactic.
Sent home on a beta blocker and was able to follow up over telemedicine in the outpatient cardiology clinic that way. So a lot of my time, again, that's kind of a little all about the ER ICU stuff I wanted to talk about, and I want to touch on a couple of other things briefly before finishing, is that we provide a lot of, I just got this off of the web last night. We have 18 clinical services that we're able to provide, and again, these are all on the web. We have referral guidelines, what our specialists can see over telemedicine, when, where, the 85 different sites, all of that stuff. And so I spend my time going around to the different divisions and things like that to say, hey, is there a way that these technologies might be able to, you know, as a part of your vision for your program, you know, and it's work to get this going. You know, a lot of the different divisions look through and say, yeah, I have patients travel in 3.5 hours. I never thought about this. And then they kind of had to go through and see where they're coming from, and then we hook them up in a telemedicine clinic. But it takes an initial kind of like overcoming inertia to get them involved with telemedicine that way. But once they're involved, generally speaking, they like it very, very much. But again, we're trying to expand this to not just physician services that way. Our psychologists, our pediatric psychologists are very active using telemedicine. We do this they do this parent-child interaction therapy, and it's a teach-the-teachers model that way, and they've done more than 1,000 teach-the-teacher encounters this way over video conferencing rather than traveling to do behavioral pediatrics this way. Our audiologists, and I think I have a slide on this next, are using it, our pediatric audiologists. Our nurse practitioner for ENT, cleft lip, cleft palate. We've done lactation consultants, babies born in the Sierra Nevadas, can't get in with a cleft lip. You know, and it's amazing to see lactation consultant, ENT, nurse practitioner talking with his family. I was just watching it, and you know, tears streaming down the mother's face as she's breastfeeding because the local pediatrician said, you know, you can't breastfeed. Your baby's going to be tube fed, you know. And but we were able to get a lactation consultant right there and help the mom out. So good stuff with that by the non-physicians. Our physiologists are working with physical therapists, occupational therapists, and speech language pathologists as well. I'm not sure if you have a similar model in the DC area. for children with special health care needs to prescribe their therapy and durable medical equipment, but in California that's required to be headed up by a physiatrist, and they're now doing more and more encounters this way over telemedicine. Dr. David Steinhorn, who's here, we're still working on doing palliative care services for patients at home, Duchenne muscular dystrophy, things like that, be able to take the care to them as opposed to having them have to pack up all their equipment and come in to the clinics that way. A quick example on our teleaudiology service, Northern California had one of the highest loss to follow-up rates for babies that failed their newborn hearing screen. So they have a newborn hearing screen. If you fail that, you have to have what's called a diagnostic evaluation to follow up. They repeat the test. Was it a false positive? Figure out what's going on. Does a baby need hearing aid, cochlear implants, therapy involved? What's going on here? And we know we had one of the highest rates in the country because folks from HRSA contacted me directly to say, hey, you guys are not doing so good up in Northern California this way. And what we did is we set up, and there's no pediatric audiologists north of us, to the northern part of the state. So we set up all of the teleaudiology equipment up in Redding, California, which is central to all of this. And we've really essentially dropped this loss to follow-up rate using this model to zero. Because as it turns out, a lot of these parents, families weren't following up just because of the distance. And even getting to Redding, sometimes it'll be like, can't make it on Tuesday, I get paid on Wednesday, can put gas in my car on Thursday, I can make it Thursday. But having them to come, 4 hours for that drive and pay for parking, they just wouldn't do it. I also learned that middle ear muscles have reflexes working with the audiologists. Little hammers. There's also just another brief thing, not from UC Davis, but up in Rochester, New York. Again, I wanted to talk about how they're doing it for school-based telehealth. They have telehealth assistants, which are not medical assistants, but they're actually they can be the staff in the daycare, or they can have telehealth assistant travel out to the daycare center or the school. They have more than 40 sites that are participating, and it's connecting up these children from the daycare centers and the schools to their primary care providers. So it's not just all through the University of Rochester, but it's through their primary care providers, as well as the Rochester, if that's where the patient's PCP is. And they've done more than 7,500 visits this way. They've got insurance to pay for it. They did a lot of study data with this. I think this was published in Pediatrics also about 8 years ago to show that the days absence due to illness from daycare were dramatically used using this model of care, right? Rather than calling the parent, hey, come pick up your kid, he has a snotty nose or, a low-grade fever or something like that, they're able to get the pediatrician there and see the child that way. And a lot of times that can prevent the parent from having to leave work and come in that way. They even have it where, I guess he was telling me, where a lot of the parents will bring in their kid and they'll say, hey, Johnny has a rash. Will you have the pediatrician take a look at that? I'm off to work. And so they get this amazing care at the daycare center. And there's a couple of the daycare centers that will have the prescriptions dropped off. And so they can even look in the middle ear diagnosis of otitis media. So the parent comes off at the end of the day of work, picks up the child, and they have their antibiotics there for the ear infection that way. Again, 63% reduction in days absent. And then the concern for the payers in the state of New York was that this is going to increase utilization, right? Why do we want to pay for this? It's going to be, all it's going to be is more bills, more encounters, and things like that. And again, this was published in Pediatrics. And overall, they did show an increase in utilization here overall, the height of the graph. These are the office visits on a match cohort here, but there was a reduction in emergency department visits. So a parent having to pick up their child because they're sick, needing a note from a doctor before getting in, all of that stuff. So they were able to reduce the number of ED visits by 23% in this study. So a great model of care here. Again, I don't want to go this is one slide on home management, disease management. You guys are doing it with cyanotic control, heart disease, diabetes, asthma. There's ways to monitor how many times the kids are hitting the puffer, whether or not they're checking their insulin, right? The technology is easy, and we're able to get that in and to screen it and see if a kid's not checking their glucose, if it's out of control, if they're, stuck in on a lot of albuterol, things like that, to be able to do some home monitoring there. This is, I'm not sure if you've seen these cameras that fit over your iPhone this way that take these very, very high-resolution images as long as there's no wax in the ear of the eardrum that can be transmitted. This is just a random little technology. See, these are like little aspirin here, and they have very small microchips. And if you put this patch on your flank here, when you take the pill, you digest a little microchip, and it alerts your phone. So this is a way of verifying medication administration that way. So the VA, of course, does this a lot. So these are the 6 domains of quality of care from the Institute of Medicine, and I think hopefully I can submit to you that in a lot of cases that this is safe care, effective. It certainly is patient-centered. Hopefully it breaches the equitable when we're reaching out to those in rural and underserved areas, and hopefully it certainly can be timely. I'd like to point out 2 publications that came out in the American Academy of Pediatrics. The first one here is a technical report. Doggone, I don't know, but Dr. Sable's probably an author on this, on the applications of telemedicine, and there is another one put out by the Committee on Pediatric Workforce, the use of telemedicine to address physician shortages in workforce issues. So if it's so awesome, why isn't it everywhere? And I have to admit that there still are some barriers. Aligning investments with the savings. So if I keep a kid out of my ICU, that's not so good maybe for the bottom line of our ICU. And I remember at one point the chief coming up to me, slapping me on the shoulder and saying, if you keep this up, you're going to be out of a job, which I was thinking that may not be such a bad idea. No. But, of course, it's the right thing to do. And as we go from volume-based to value-based, that's going to really align the savings, right? If we save a helicopter ride, it's not money in our pocket, right? It's money saved by the payers. That's either the state or the insurance company. Equity and reimbursement, that's up to the state. I'll have a quick brief mention of that later. And, again, the funding of the equipment to telecommunications is an issue, but hopefully that's becoming more reasonable. As things become less expensive, there are regulatory barriers. Credentialing by proxy is something that we do. A lot of our sites, we just send them our credentialing packet and they can sign off on that. It's not so easy. It takes changes to their med staff bylaws and things like that, but that's an existing barrier. If we went across state lines, we have to get medical licenses in the other states. And then just there's a frank shortage of physicians, right? So it's not like there's a lot of docs that are sitting on their hands going, gosh, I wish I could see more patients, or I've had a whole afternoon to see patients over telemedicine. So to the degree with which we can introduce efficiency into the practice this way, education of primary care providers, I think it can be a solution to this way. Engaging the physicians, often it's the biggest barrier. Engaging the consumers is not the biggest barrier. And this, I usually end it with that slide, but I have to come up with the questions and be proactive here. People often ask about, what about payment? For the Medicaid side, that's left up to the states. California, if I see a patient, inpatient, outpatient, I get paid the same as if I were to see that patient in person. There's documentation, not tricks, but there's ways to document that. And there's a lot of resources. One is the Center for Telemedicine and eHealth Loss, CTEL here in Washington, D.C., and then the HRSA Telehealth Resource Center, designated Center for Connected Health Policy, which is a national resource center for telehealth policy issues or questions, and they're located in Sacramento. And then people always ask about liability, and I think that that's, for them, I don't want to totally brush it off, but it's not as big an issue as people would think about it. Our lawyers tend to think, hopefully, if we're seeing a patient, we're more likely to give better advice than if we're not seeing the patient. And actually, there's been several, and an increasing number now, of lawsuits in the opposite direction, and in particular for adults presenting to an emergency department with a stroke. They don't have a stroke neurologist. They were TPA eligible, and they're suing the hospital, trying to sue the hospital, saying, hey, if you had telestroke services here, my parent could have gotten TPA. And, it's a technology now. It's almost becoming a standard of care in that respect. Review, telehealth, I think, can hopefully help address the triple aims, the IHI, population health, experience of care, and in some circumstances reduce per capita costs. There's a lot more applications than the typical outpatient, and again, I'm just touched on some of those briefly. Barriers certainly still do remain and more so the consumers are demanding it. I didn't even go into the direct-to-consumer telehealth where people can go online and get a doctor from gosh knows where that doesn't have access to their medical record, but that's an increasing number. There's been 500,000 of those last year, and of course that market's expected to grow as well. And so again, this has been a super-duper honor, and I wanted, I don't know if you know this, but I'm at UC Davis in Sacramento, but there's a Dr. Robin Steinhorn and Dr. David Steinhorn that you guys kind of stole from us, and I was kind of wanting to get the swag back that they have, because we got I'm not sure what you're going to do with that tattoo, Robin, but if all of the Aggie stuff. But anyways, thank you so much for the invitation.
Do you have time for some questions?
Thank you so much. That was a fabulous presentation.
Thank you. Thank you.
And yes, we did break Taubin. I have a question for you in terms of your experience with the private payers. You mentioned that with Medicaid on one of your slides, you know, the services. Talk to me about the negotiations with private payers.
So generally speaking, they'll follow our state Medicaid, Medi-Cal, so we get the same reimbursement from private payers as in person, so there's equitable. More than half of the states in the country have telemedicine parity laws. Some states do not, but typically they'll kind of do whatever Medicaid says for the pediatric population.
Hi, Jim. Congratulations on a great talk. Jim's definitely one of the leaders in advocacy for pediatric telemedicine. He single-handedly started the special interest group for pediatrics in the American Telemedicine Association, which has a huge impact on our field. In terms of the ICU delivery, one of the pushbacks we're getting from local ERs is they want ICU doctors to be providing the service as opposed to emergency care. So what is the role of your emergency room doctors in your relationship with these outside hospitals? How does that integrate with your ICU team?
Yeah, so that's a good question. Now, I know this is a general statement, but in large children's hospitals like yours, the ER does a lot of the transfer of care, the EMS care. In our hospital, it goes directly to the ICU doctor. So our ER doctor, a lot of times we'll pull them in when it's a question appropriate for the emergency department physicians to be able to answer those questions. But it just so happens our model of care, all the calls go to the PICU doc as opposed to the ER doc. But there's other models that are out there, folks that are using telemedicine, where it's the ER doctors that are doing this type of care. Does that answer the question? Or, all right, thanks. Hi, Shireen.
Thanks for a great talk. Can you tell me how you're using telemedicine at UC Davis to enhance resident and fellow education?
Good question. So when they do their residency electives, if they're on endo, neurology, or whatever it is, they're joining the attending on telemedicine that way. And we recently started, this is just since your departure, Robin, but we recently started a telemedicine elective in the residency program. I think, so there's, telemedicine's a little bit more in the blood of everybody that works at UC Davis. Everyone knows that we do a lot of telemedicine, and I think that that's good stuff. So when those folks are trained and they go out in the community, they know about it, and we get actual demand for it. It's like, hey, I want you to provide my patients with telemedicine this way. So it's kind of, it's not necessarily separate other than that elective, but it's kind of integrated into their daily routine. When I'm in the ICU doing telemedicine, they're always like looking over my shoulder, looking at what I'm doing, and certainly a couple of them have worked on research projects as well. But good question.
Hey, Jim, thank you. Wonderful talk. Great to see you here. And thank you for your advocacy in pediatric telemedicine. You didn't talk a lot about any direct-to-consumer efforts that UC Davis has. Could you talk about that a little bit? And it looks like most of the encounters are done in the physician's office. Is that because of reimbursement?
Right. So a lot of the home management, of course, you're not necessarily going to be paid for that, right, in the current model of care. We're trying to pass legislation in California where you can get paid for that. But to be honest, even though delivering it to home can help prevent, you know, admissions in the emergency department, that's been shown with congestive heart failure, a lot of adult stuff. the model of care where you don't get paid to see a patient at home, unfortunately. So I think the biggest barrier for home telemedicine or direct-to-consumer telemedicine is reimbursement. Again, you mentioned there's this growing, our providers are not providing direct-to-consumer telemedicine right now through the telehealth or the MD Live models of care or American Well, but that certainly is a growing market, in a way a big threat to the pediatric medical home. So we're working with the American Telemedicine Association and the AAP to kind of have guidelines and regulations on how that's done. Those are great questions.
Two questions related to reimbursement. First of all, if someone calls me and I make a consultation, do I get paid for that consultation, or is it the person who's calling gets paid for the visit? And the second thing is, if a family calls in and they use telemedicine for a rash, can I charge for that?
Okay, so for the first one, if you're talking about the model of care where they're in the clinic, so it's the same thing as if you were to think about it in person. It can't be, you can't submit charges for the same condition. But if the PCP is doing an annual physical exam or something like that, in addition, they both can submit and get paid for the physician services. So the specialists will get paid for their physician services. On the hospital side, there may not be, there's not the clinic fee, or what's that called, the facility fee, right? So that there is some small payment to the originating site where the patient is, they would get that facility fee. So with regards to the rash, that's going to totally depend upon the insurance company, whether the patient's at home or not. It's distressing now because a lot of insurance companies, and this is true in California, where they have, through their insurance, CalPERS, which is the largest public health system in California that insures doggone 400,000 people in California. They'll support patients that use direct-to-consumer, so they can get a doctor from anywhere, and those doctors will get paid to see the patient at home, but they won't pay their primary care provider for doing that exact same care. So there's battles to be fought in terms of equity of payment that way. So. Oh, WebEx, yeah.
Oh, we have a WebEx question, thank you. Have you seen telemedicine used to triage patients from home to decide whether they need to come to the ED or can just visit their PCP the next day?
Great. So that's
a great question from Jim Chamberlain, actually.
That's exactly how these direct-to-consumer models are doing that. The reason that the 5 largest health plans in the country are paying to have this done by these third-party companies is if they can, see 10 patients and prevent 1 ER admission, they're going to save money that way. And so that's a big emerging market. I think it's a little bit incumbent upon us to be able to get involved with that, right? So we do this as, I say we, general pediatricians do this every day anyways, right? They take telephone calls. They do all of the triage for this. They help determine which child goes to the emergency department, and they don't necessarily get paid for that. But now there's this emerging market where they're using video conferencing to do that, and it's a hefty copay. The other thing is that's not very equitable care. You have to pay $40 to $70 for a copay to access one of these things, and not all families, of course, can do that. But so, again, we're trying to get equity in payment for that.
Can you tell us a little bit about how, for example, subspecialists would document the consultation?
Right. So it's the same. Everything's going to be based off of the notes from the biller's perspectives and things like that. And so when it's like the typical ICU doctor physical exam. You stand at the bedside. No. Sometimes we touch a patient. But we write like neurologic exam, whether they're moving all, the work of breathing. We can see their face. We can say, their mental status. We can comment on all of those things. When it comes to like lung sounds, what I do in my notes is I'll say the work of breathing is minimal, there's no retractions, there's no wheezing per the bedside RT or nurse. The same thing with the belly. Oh, it's slightly distended, but per the bedside nurse or doctor, it's soft and things like that. And I document that in the physical exam that way. And we've been tracking this, and the line I like to say is that our denial rates are exactly the same as they are for in-person when we use telemedicine. So that physical exam is appropriate that way. But otherwise, it's the same components of the regular exam. So yes, our system is such that the calls from the outside, an MR number is immediately generated by our transfer center. I document in my medical record an Epic with the dot phrases and things like that. And then the transmission part is still, some of it we can document as a CCD electronically, some of it we have to fax, some of it we mail, but it's in our electronic medical record. So if the patient comes to our hospital, our ER docs will have that. Same with outpatient.
Could you give us a couple examples of how this fits in the workflow of the physicians who are doing the consultations, from the ICU or NICU or other places when you get these calls? How do you kind of juggle your in-person activities and your telemedicine activities?
It's the same, for the ICU, NICU, it's the same way we juggle everything else. The patients at the bedside, the telephone calls, and telemedicine. And I kind of want to make this point that I think is very, very important. It's a common concern. It's like, oh my gosh, we need to get more staffing, and I have to look at the patient, talk to the family. And I think that the culture in our ICU has really, really changed such that when you get a call and the doctor says, I have this pretty darn sick kid, they're like, put telemedicine there. I want to see that kid, because that's the right thing to do. That's what we're paid to do, is to be able to evaluate these kids. And it's the same thing if you get a call from a nurse, like, hey, the kid's working hard to breathe, and you prioritize it. Sometimes we're in the middle of a procedure, and we get a telemedicine call. We have a backup system, and we can do it from home. I can do it from home, which I do not infrequently. But, hey, let's deal with this over the phone right now. I'll take a look at the kid when I get a chance. Everything is prioritized that way. And again, but it's the same telephone. There's 5 locations in our PICU where our docs can connect to. 3 clicks of a mouse, and you can be connected in an emergency department. You put on a headset, try and make it very easy. The medical record number's right there. It's all meant to be very, very seamless for that. And the same thing with the outpatient clinic. These are all scheduled and coordinated by a telemedicine coordinator. The doc can come in for an afternoon, a full day of telemedicine clinic, sit in front of the monitors. Okay, I'm ready for my next patient. They drop them in the virtual room, and again, there's a lot of effort, as there should be, to make it very efficient for the physician.
The clip he showed of Dr. Poulain with the cohort at the small rural hospital, this was at 1:30 in the morning, and he connected. It was his first telemedicine consult. He connected from his computer at home and stayed on that computer for 2 hours. So the technology has to work, but when it works, it fits right into your workflow. So thank you very much.
My pleasure. Thank you, everybody.
For just a wonderful presentation.